You are sitting in the testing center. A 75-word cardiac scenario appears on your screen, complete with 5 vital signs, 3 lab values, and a list of vague patient complaints. Your clock is ticking down, and you have exactly 1 minute to decide what to do first. It is easy to freeze in this moment, but you do not need to memorize every single clinical detail in your textbook to choose the correct answer. What you actually need is a step-by-step, repeatable framework. We are going to build a decision-making system that automatically filters out the distracting details, so you can immediately identify who is in danger and exactly what action to take. By relying on a strict set of clinical rules rather than rote memorization, you can approach these high-stakes questions methodically. You evaluate the data, apply the rules, and select the safest intervention. This system converts exam anxiety into rapid, confident clinical decisions. This matrix shows the 4 foundational decision rules. First, airway, breathing, and circulation always take precedence. Second, unstable patients require attention before stable ones. Third, acute conditions demand action over chronic conditions. And fourth, unexpected findings are a higher priority than expected findings. Let's apply that. If a patient with chronic venous disease reports heavy, swollen legs, that is a chronic expected finding caused by blood pooling. But if a patient suddenly develops shortness of breath while making their bed, that is an acute, unexpected symptom requiring immediate intervention. Now we apply this matrix directly to cardiac care. High-yield warning signs must immediately trigger your priority response. Your first 3 absolute priority indicators involve sudden vital sign shifts, sudden chest pain, a drop in blood pressure, or extreme heart rates, specifically anything dropping below 60 or spiking over 150 beats per minute. The final 2 indicators round out your priority list: the universal need for early oxygen and the critical nature of any new, sudden onset symptom. Prioritizing unstable and unexpected symptoms ensures you address immediate physical threats first. Following these triggers guarantees you will not overlook a life-threatening complication hiding behind a routine patient complaint. This flowchart maps the rigid order of operations a nurse follows when intervening. Identifying the problem is only the first half of the exam. The second is taking action in the correct sequence. Step 1 is always to assess the patient first. Step 2 is to apply oxygen to stabilize their breathing. Step 3 is to establish IV access to secure a route for fluids and immediate intervention. Step 4 is to administer prescribed medications. Step 5 is to secure a 12-lead ECG to analyze the cardiac rhythm. And Step 6 is to prepare for reperfusion procedures, like a cardiac catheterization. While knowing what to do is critical, knowing what to avoid is equally important. Your clinical sequence includes hard stop triggers for specific medications. For example, you must hold beta blockers, like metoprolol, if the heart rate drops below 60, and you must hold cardiac glycosides, like digoxin, if the patient reports visual changes, like yellow or blurred vision, which indicate toxicity. Sticking to this strict 6-step sequence guarantees your patient's ABCs are stabilized before you introduce medications or delay care for time-consuming diagnostic tests. Let's use this framework to defeat the most intimidating format on the nursing exam: select all that apply questions. The primary strategy here is to eliminate guesswork entirely. This interface demonstrates the true-false method. Instead of looking at the options as a group, you evaluate every single option independently. You ask one question for each choice: is this action safe and necessary for this specific patient? On the exam interface, the patient presents with angina, shortness of breath, and diaphoresis. These findings indicate an active compromise to circulation and oxygenation, allowing you to prioritize them over stable findings like weight gain or stasis dermatitis. Next scenario. The data shows a regular rhythm, indiscernible P waves, and a heart rate of 145. That specific metric confirms the patient is in supraventricular tachycardia. The immediate action is to have the patient perform vasovagal maneuvers, such as coughing forcefully. Now we apply the medication hold rule. You have a patient with coronary artery disease receiving metoprolol. The assessment shows a heart rate of 52. Because that metric falls below the hard stop trigger of 60, you must intervene and hold the dose. Finally, a patient progresses to an ST elevation myocardial infarction. The ST elevation indicates complete coronary occlusion. Evaluating your options through the matrix confirms that the required intervention is an immediate heart catheterization and percutaneous intervention within the 90-minute window. Let's run a few rapid decision drills. If the stem presents sudden chest pain, your immediate matches are applying oxygen, administering nitroglycerin, and getting an ECG. If the stem presents an unstable lethal rhythm, your immediate match is defibrillation. If the patient exhibits symptomatic bradycardia, you match that to atropine. And if you need to evaluate the severity and risk of death for a heart failure patient, your match is the BNP lab test. By treating every select all that apply option as a strict true or false statement, you remove the ambiguity from complex cardiac scenarios. You now have a complete testing arsenal. You have the ABC priority matrix to identify who needs you first, the rigid 6-step intervention order, and the true-false method to systematically eliminate incorrect options. When you sit down for the exam, trust these established rules. The question stems often contain distracting data, but the clinical indicators remain consistent. You have the framework. You know which metrics demand action. Apply the rules step by step, and you are fully equipped to safely and confidently conquer any cardiac question on your exam.